Okay, let's unpack this. We are diving deep today into something that works tirelessly behind the scenes, um, utterly crucial for your daily comfort and clear vision, your tears, and the incredibly intricate system that produces and manages them, the lacrimal apparatus.
It really is. It's one of those systems you just, you don't notice when it's working perfectly,
Right.
but when it's not, well, it can cause significant discomfort and problems.
Absolutely. And for this deep dive, which is specifically tailored for you listening now, we're going to take the stack of source material you've shared and really go through everything. Your goal is mastery. You want to understand this topic like an elite professional.
Like the experts in the field.
Exactly.
Gotcha.
So that means we won't just skim the surface. We're extracting every important nugget, every concept, every detail mentioned in these texts you provided.
Think of this as your guided tour. We'll cover the anatomy, the physiology, what happens when things go wrong, how we diagnose those problems, and even the real nitty-gritty of how they're corrected, including surgically.
Precisely. We'll break down the structures, understand the fascinating way they work together, explore common issues like, dry eye and blockages, touch on those less frequent gland problems.
Which are rare but important.
Right. And then, yes, we will get into the detail of how doctors figure this stuff out and the specific ways they treat them, including those surgical procedures described in your sources. It's all about building that deep, expert-level knowledge base for you.
Okay, I'm ready. Let's begin that exploration.
All right, let's jump right in with the building blocks. The source material points out that the lacrimal apparatus essentially has two main functional divisions. You've got the parts that make the tears,
The lacrimal glands.
and the parts that drain them away.
The lacrimal passages, that diagram mentioned, figure 24.1, is really helpful for visualizing this basic split.
So on the production side, the main lacrimal gland, it's got two lobes.
That's right. There's a larger one, the orbital or superior lobe. It's tucked away up under the bone, about the size of a small almond, sitting in what's called the lacrimal fossa of the frontal bone.
Hidden away.
Pretty much. Then there's a smaller palpebral or inferior lobe. It's really just a few lobules sitting lower down, right on the path of the ducts, coming from that main superior lobe. You can actually get a glimpse of this smaller lobe if you gently lift and turn out the upper eyelid and look up and inwards.
Okay, one hidden, one slightly more accessible. And the ducts from the main gland, how do they get the tears out?
About 10 to 12 small ducts come from that larger orbital lobe. But here's a key point. They don't just go straight to the eye surface. They actually pass through the smaller palpebral lobe before they open onto the conjunctiva.
Where exactly?
Right at the outer edge of the upper fornix, that kind of cul-de-sac under the upper eyelid.
But hang on, the source also mentions accessory glands, Krauss and Wolfring, and these seem really important, right?
Ah, yes. This is a critical insight for truly understanding tear production, something often overlooked. You've got these microscopic accessory glands. Morphologically, they look identical to serious salivary glands.
Where are they located?
The Krauss glands are mostly found in the lateral upper fornix. The source says about 42 in the upper lid, fewer, maybe 6 to 8 in the lower. The Wolfring glands are nearer the upper border of the tarsus, that firm plate in the eyelid. Together, they make up about 2/3 of all the accessory glandular tissue.
And their ducts also open into the fornix.
Yes, their ducts unite and open there too.
So what's the vital functional difference? This seems key for the mastery goal.
Here it is. The main lacrimal gland, the big one, is primarily for reflex tear secretion. The heavy tearing when you cry or get dust in your eye.
Got it.
The accessory glands of Krauss and Wolfring are the real unsung heroes. They provide the basic continuous tear secretion, that essential moisture layer that's on your eye all the time, keeping it comfortable, even when nothing's stimulating extra tears.
Wow, okay. I honestly didn't realize the everyday moisture came mainly from those accessory glands. That's a fascinating detail. Right, so tears are produced. Now, how do they get off the eye surface? That brings us to the drainage system.
The lacrimal passages. Exactly. It's like a little plumbing system. Starts with those tiny openings you might have noticed near the inner corner of your eyelids.
The lacrimal puncta, those little dots.
Those are the ones. Located near the posterior border of the lid margin, about 6 millimeters from the inner corner, usually on a tiny elevation called the lacrimal papilla. Normally, you'd only see them clearly if you gently avert the lid slightly.
Okay. And from the punctum, tears flow into the canaliculus.
Correct. Each canaliculus, there's an upper and lower one, has a short vertical bit, maybe 1 to 2 millimeters long. Then it turns sharply at a little widened spot called the ampulla and runs horizontally for about 6 to 7 millimeters towards the nose.
Do they join up?
Usually, yes.
Mm.
The upper and lower canaliculi typically join to form a common canaliculus just before entering the outer wall of the lacrimal sac. And there's a little folded mucosa there called the valve of Rosenmüller.
Like a check valve.
Exactly like that. It helps prevent tears from refluxing, falling back out of the sac into the canaliculae.
A one-way street into the sac. Tell us about the lacrimal sac itself. Where does it sit?
It sits in a bony depression, the lacrimal fossa, which is formed by the lacrimal bone. When it's distended, it's maybe 15 millimeters tall and 5-6 millimeters wide. The upper part, the fundus, actually extends slightly above the medial palpebral ligament.
And muscles are involved.
Yes, importantly, it's surrounded by fibers of the orbicularis muscle, the muscle that closes your eyelids. Remember that, because it's crucial for how the tear pump works. The lower end of the sac then narrows down and connects to the nasolacrimal duct.
Which is the final leg of the journey, taking tears down into the nose.
Precisely. The nasolacrimal duct is a tube, maybe 12 to 24 millimeters long and about 3 millimeters in diameter. It's bordered by parts of the upper jawbone, superior maxilla, and the inferior turbinate bone inside the nose.
And its path.
It travels downwards, but also slightly outwards and backwards. It eventually opens into the front part of the outer wall of the inferior meatus of the nose. There's another mucosal fold down there, the valve of Hasner, at the nasal opening, which can close off the duct end when needed.
It really is a complex little plumbing system hidden away there. The source even dives into some histology for that deeper understanding.
It does. The sac itself is lined by pseudostratified columnar epithelium. Its walls contain elastic tissue and also lymphoid tissue, suggesting an immune function. The periorbita, that lining of the bony orbit, splits to form a fascia, the lacrimal fascia, which covers the sac.
And those muscle attachments you mentioned.
Key details. The deep head of the orbicularis muscle, sometimes called Horner's muscle, is located behind the sac, attached to the posterior lacrimal crest. The superficial head of the orbicularis attaches anterior to the sac on the anterior lacrimal crest. This arrangement is vital for the pump action.
I see. And the surface marking of the nasal duct, you can sort of trace it on your face?
Roughly, yes. Line from just outside the inner corner of your eye down towards that groove between the side of your nose, the ella, and your cheek. And an interesting anatomical point. The narrowest part of that entire duct is right at its upper end where it joins the sac.
And the linings are different in different parts.
Yes, a subtle but important histological difference. The canaliculi are lined by non-keratinized stratified squamous epithelium, like skin, but without the keratin. The sac and the duct, however, have that columnar epithelium sitting on a layer called the corium, which contains a rich network of veins, a venous plexus. And that mucus lining down at the bottom forms what the source calls an imperfect valve at the nasal opening.
Okay, structures covered. How do tears actually move through all this? You mentioned capillarity and this lacrimal pump.
Right. Under normal conditions, those accessory glands produce just enough tear fluid to keep the eye nicely moist. About 60–70% of this fluid enters the lower canaliculus simply by capillarity. Like water wicking up a paper towel.
Yeah.
That physical force draws the fluid into those narrow canaliculi. Some tear fluid also evaporates naturally from the eye surface.
But when you have excess tears, like when you're crying or something irritates your eye.
That overflow only happens under reflex stimulation, either emotional, psychical, or from peripheral irritation, like dust or fumes. That's when the lacrimal pump mechanism really kicks in to actively drain the tears, both the normal flow and any excess. It's powered by blinking.
How does blinking drive it?
As your eyelids close, they move from the outside corner towards the nose. This movement sweeps the tear fluid medially, pooling it in the inner corner, in the lacus lacrimalis. Then, crucially, as the orbicularis muscle fibers around the lacrimal sac contract during the blink.
They squeeze the sac?
Actually, the opposite initially. They pull on the lacrimal fascia surrounding the sac. This pull widens the sac, creating a negative pressure inside.
Ah, the suction.
Exactly. It effectively sucks tears in through the puncta and canaliculi, drawing them from the lacus lacrimalis into the widened sac. Then, when you open your eye, the orbicularic relaxes. The pressure is released, the elastic walls of the sac collapse somewhat.
Pushing the tears down.
Yes, pushing the tears down the nasolacrimal duct into the nose. Gravity helps a bit too, of course. It's a really elegant little hydraulic pump powered by every single blink you make.
Ingenious. Okay, so the tears themselves, what are they actually made of and what are they doing besides just wetting the eye?
Tears, as we said, are formed by all those glands. Chemically, they're a slightly alkaline solution, mostly sodium chloride salt water, basically. but their function is much more complex than just lubrication, and the source makes this clear. Understanding this is vital.
So beyond lubrication.
Way beyond. First, yes, lubrication for smooth eyelid movement. Essential. Second, it creates a perfectly smooth optical surface over the cornea. This is critical for clear vision because it fills in any tiny irregularities on the corneal surface itself.
Like polishing the lens.
Exactly. Third, it provides essential nutrition, particularly oxygen, to the cornea, which lacks its own blood vessels. And fourth, it acts as a protective barrier, washing away debris and defending against injury and infection.
And the source breaks down that tear film covering the eye into 3 distinct layers. Each has a specific job.
Yes, mastering this system means knowing these layers. Closest to the eye surface is the posterior mucus layer. This is produced by specialized goblet cells in the conjunctiva. Its job is to help the tear film spread evenly across the eye and adhere tightly to the corneal epithelium.
Making it stick.
Right. Then comes the middle and largest layer, the aqueous layer. This is the watery part, secreted by both the main and accessory lacrimal glands. This is the layer that does the flushing, washing away particles and irritants.
In the outermost layer.
That's the superficial oily or lipid layer. This comes from the meibomian glands, which are located within the eyelids. This oily layer does 2 key things. It creates a super smooth surface for light to pass through, and very importantly, it prevents the watery aqueous layer underneath from evaporating too quickly.
Like a little lipid cap on top. It's like a microscopic shield. And the source mentioned tears have a bacteriostatic property.
They do. They contain an enzyme called lysozyme. Lysozyme has antibacterial properties. It helps inhibit bacterial growth, adding yet another layer of protection for the eye.
There was a note in the source about xerosis, or dryness, that seemed a bit counterintuitive based on what we just said about the main gland being for reflex tears. It said, removing the main lacrimal gland doesn't usually cause severe dryness.
That's a really important detail from the source, highlighting the functional difference. Because the accessory glands of Krauss and Wolfring, along with the conjunctiva's mucus cells, are responsible for the continuous basal secretion. Removing the main gland, which primarily produces reflex tears, often doesn't result in severe dry eye symptoms. It really underscores just how vital those accessory glands are for maintaining basic, everyday moisture.
Okay, that deepens my understanding considerably. What about the nerve supply that controls all this? How are tears turned on and off?
Ah, the neural control. This is truly fascinating and absolutely crucial for a comprehensive understanding. The lacrimal gland's activity is controlled by the autonomous nervous system, both the parasympathetic and sympathetic branches.
Let's trace the parasympathetic path first. That's the one that stimulates secretion, the secretomotor pathway, right?
Yeah, and it's quite a complex journey. It starts with neurons located in the superior salivatory nucleus, which is in the brainstem. Their nerve fibers, the axons, travel out with the facial nerve, the 7th cranial nerve.
Okay.
Then they branch off as the greater superficial petrosal nerve. This nerve travels through a hole in the skull base called the foramen lacerum, and then joins up with the deep petrosal nerve to form the nerve of the pterygoid canal, also known as the Vidian nerve.
Following so far.
This nerve then travels to a structure called the pterygopalatine ganglion, located deep in the face in the pterygopalatine fossa. Here, these parasympathetic fibers make a connection, they synapse.
The relay station.
Exactly. Then, the postganglionic fibers leave the ganglion. And here's the surprising bit. They essentially hitch a ride with branches of a different cranial nerve, the trigeminal nerve, the 5th cranial nerve. Specifically, they travel with the zygomatic nerve first.
Part of the trigeminal.
Yes, a branch of the maxillary division.
Yeah.
The zygomatic nerve then sends a communicating branch over to the lacrimal nerve, which is itself a branch of the ophthalmic division of the trigeminal nerve. Finally, these parasympathetic fibers travel along the lacrimal nerve to reach the lacrimal gland and stimulate tear production.
Wow, that's quite the detour. Starting with the facial nerve, synapsing, then jumping onto trigeminal branches to finally get to the gland. What about the sympathetic supply?
The sympathetic fibers are primarily vasomotor. Their main job is to regulate blood flow to the gland, not directly stimulate secretion in the same way. These fibers originate from the superior cervical ganglion in the neck. They travel via the deep petrosal nerve, join the Vidian nerve, and pass through the pterygopalatine ganglion without synapsing.
Just passing through.
Just passing through. Like the parasympathetic fibers post-synapse, they then travel with the zygomatic nerve and its communicating branch to the lacrimal nerve to reach the gland.
So the pterygopalatine ganglion is a key relay for the tear-producing parasympathetic signals, but just a pathway for the blood flow regulating sympathetic ones.
Got it. And the nerves supplying the sac and duct themselves.
They receive their nerve supply from different branches, specifically the infratrochlear nerve and the anterior superior alveolar nerves, which are also branches related to the trigeminal system. It's a really layered and interconnected system of neural control.
Right, that gives us a really solid foundation on the healthy system, how it's built, how it works, how it's controlled. Now let's shift our focus, as the source does, to what happens when things go wrong. First up are diseases of the lacrimal gland itself. The source mentions these are relatively rare.
They are, certainly compared to problems with the drainage passages. The first condition listed is dacryoadenitis, which is simply inflammation of the lacrimal gland.
What typically causes that? It can sometimes occur as a complication of general systemic infections. Mumps is mentioned, influenza, and particularly infectious mononucleosis, or mono.
What are the symptoms?
You might see a red, painful swelling, specifically in the outer third of the upper eyelid. With infectious mono, this can be associated with follicular conjunctivitis, swelling around the eye, periorbital edema, inflammation inside the eye, uveitis, and sometimes even inflammation of the optic nerve, optic neuritis.
That sounds quite involved. What's the typical outcome?
Usually it's self-limiting, meaning it resolves on its own. However, the source notes that occasionally the central nervous system can be involved, which is more serious. And if an abscess forms within the inflamed gland and bursts through the skin, it can unfortunately result in a permanent fistula, a persistent opening draining fluid.
Okay. The source also lists Mikulicz syndrome. What's that?
Mikulicz syndrome has a very characteristic presentation. Symmetrical enlargement of both the lacrimal glands and the salivary glands, like the parotid glands. The underlying cause, the etiology, can vary, but often the swelling is due to lymphomatous infiltration. You also see this pattern of enlarged parotid and lacrimal glands in something called uveoparotid inflammation, which is often linked to sarcoidosis.
And dacryops, that sounds different.
Dacryops is a cystic swelling. You typically see it in the upper fornix, under the eyelid. It's caused by retention of the gland secretion because one of the lacrimal ducts gets blocked. The source notes you can distinguish it from a simple retention cyst of one of the tiny Croce glands by its specific position, usually higher up in the fornix.
Then we move on to tumors of the lacrimal gland. The source says they behave somewhat like parotid gland tumors.
They share some similarities, yes. The most common type of lacrimal gland tumor is the pleomorphic adenoma, also known as a benign mixed tumor. It's non-cancerous. Among the malignant or cancerous types, most common is adenoid cystic carcinoma.
How would someone with a benign tumor typically present? What would you notice?
Benign mixed tumors usually show up in middle life. They tend to cause slowly progressive, painless swelling in the upper outer part of the eyelid area. As they grow larger, they can start to push the eye forward, causing proptosis or downwards and inwards. Bone invasion isn't typically seen with these benign tumors. Figure 24.2 in your source material apparently shows what this might look like, its histological appearance, and how it displaces the globe.
And the treatment for benign?
They should be surgically removed, making sure to get the entire tumor out within its surrounding pseudocapsule to prevent recurrence.
And malignant tumors, how do they differ in presentation?
Malignant tumors tend to occur in older individuals and usually have a much shorter history. They grow more rapidly. A key distinguishing feature mentioned is often pain. Signs that should raise suspicion for malignancy include a painful tumor, any evidence of bone invasion on imaging scans, or the presence of calcification within the tumor.
How is malignancy confirmed?
Diagnosis requires a biopsy, often performed through an incision hidden in the eyelid crease, called a transeptal incision. If malignancy is confirmed, the treatment is typically radical surgical removal, which can be quite extensive.
And just to clarify, regardless of the cause, whether it's inflammation like dacryoadenitis, a cyst like dacryops, or a tumor, any significant swelling of the lacrimal gland can physically affect the eye's position and movement, can't it?
That's absolutely correct, and it's an important clinical consequence. A large swollen gland, particularly in that upper outer quadrant, will inevitably push the eyeball downwards and inwards. This can mechanically restrict eye movements, especially movement outwards, and particularly outwards and upwards. You might also see some degree of proptosis where the eye appears to bulge forward slightly.
Okay, that covers the less common issues with the production side, the gland itself. Now let's turn our attention to something incredibly common, dry eye disease.
Yes, this is a huge topic in ophthalmology. It affects millions of people, and the source notes it's particularly common in postmenopausal women and the elderly in general. The definition given is a disturbance of the external eye's function and protection system, which leads to an unstable tear film when the eye is open.
And the core mechanism is this unstable tear film.
Exactly. Instead of maintaining a nice, smooth, continuous layer over the eye surface between blinks, the tear film becomes unstable and breaks up prematurely. This creates dry spots on the surface of the cornea and conjunctiva.
Leading to symptoms.
Right. This repeated drying exposes the underlying epithelium, causing those classic symptoms. Discomfort, burning, stinging, a gritty or sandy sensation, sometimes even paradoxically, reflex tearing because the dryness irritates the eye. Importantly, it can also significantly reduce vision quality.
Your source material lists quite a few potential causes, the etiology. It's not just one thing.
No, the list is quite extensive, which highlights how many different factors can contribute to dry eye. It includes simply inadequate tear production, often associated with aging. Other specific causes mentioned are xerophthalmia, severe dryness, often due to vitamin A deficiency, Sjogren's syndrome, an autoimmune disease affecting moisture-producing glands, trachoma, a chronic eye infection that damages conjunctival goblet cells, reducing the mucin layer, certain collagen vascular diseases, and a number of common medications.
Which ones?
Diuretics, decongestants, some antihypertensives are listed. Also, systemic diseases like sarcoidosis can cause it, and it's noted as a potential side effect after LASIK eye surgery.
That's a wide range.
Yeah.
The classification in the source seems very detailed, which is useful for that mastery goal. It splits dry eye into two main types.
Yes, it's a helpful framework. First, there's aqueous tear deficient dry eye. This is where the fundamental problem is not producing enough of the watery layer of the tears.
And that's subdivided.
Yes, into Sjogren's syndrome, dry eye, and non-Sjogren's syndrome, dry eye. And then non-Sjogren is broken down even further into primary lacrimal gland deficiencies, where the gland itself isn't working right for unknown reasons. Secondary lacrimal gland deficiencies, due to known causes like inflammation, tumor infiltration, or surgical removal. Obstruction of the lacrimal gland ducts, so tears can't get out, and reflex hyposecretion.
Reflex hyposecretion.
That means the gland isn't getting the proper nerve signals to produce tears. This could be due to a reflex sensory block, the nerve sensing irritation aren't working, or a reflex motor block, the nerves tell the gland to secrete aren't working.
Okay, so that whole first category is about problems making enough watery tears. The second main type mentioned is evaporative dry eye.
Correct. In this type, the tear production might actually be normal or even high, but the tears are evaporating off the eye surface too quickly.
What causes that?
It can be due to intrinsic causes problems originating from the ocular surface or eyelids themselves. By far the most common intrinsic cause is meibomian gland dysfunction, or MGD. This is where the glands, the eyelids that produce the oily layer aren't working properly, so the tear film lacks that protective lipid layer and evaporates rapidly.
Other intrinsic causes.
Yes, disorders of the eyelid aperture, how wide the eye opens, problems with how the eyelid conforms to the globe surface, or issues with lid dynamics during blinking. Also, simply having a low blink rate means the tears aren't being spread often enough and have more time to evaporate between blinks.
And extrinsic causes for evaporative dry eye, things from the outside.
Exactly. These include existing ocular surface disorders, like those caused by vitamin A deficiency mentioned earlier. Contact lens wear is a very common extrinsic cause. Other ocular surface diseases or allergic conjunctivitis can also disrupt the tear film and increase evaporation.
So with all these potential causes and types, how do clinicians actually figure out if someone has dry eye, what type it is, and how severe it is? The source outlines several key tests.
Diagnostic testing is absolutely crucial. First, just careful observation with a slit lamp. They might look for particulate matter, like strands of mucus floating in the tear film, which can be stained with a dye called Alcyon blue. A cornerstone test is the tear film breakup time, or TBUT.
How is that done?
You instill a drop of sodium fluorescein dye onto the eye. The patient blinks once to spread the dye evenly across the tear film. Then, while observing with a slit lamp using a cobalt blue filter, you measure the time in seconds it takes for the first dark spot or streak to appear in the fluorescent tear film. That dark spot represents an area where the tear film is broken up and dried.
And what's considered abnormal?
A TBT of less than 10 seconds is generally considered abnormal and highly suggestive of an unstable tear film, often indicating a deficiency in the mucin layer or the lipid layer leading to evaporative dry eye.
Okay, so TBUT measures stability. What about vital dye staining?
This uses special dyes, like rose bengal, which stains bright red, or lissamine green, which stains green. These dyes have the property of staining cells on the corneal and conjunctival surface that are damaged, devitalized, or desiccated, essentially. Cells that are dried out or unhealthy due to lack of proper tear film coverage. The pattern and extent of staining show where the dryness is affecting the ocular surface.
The source also mentioned measuring the tear-lysozyme ratio.
Yes, measuring the concentration of the lysozyme enzyme in the tears. A ratio between 0.9 and 0.6 is mentioned as supporting a diagnosis of dry eye, likely reflecting reduced aqueous production.
And the classic test, the Schirmer test, can you walk us through how that's performed accurately according to the source? It measures tear production, right?
Yes, the Schirmer test specifically measures the amount of aqueous tear production over a set time. You take a specially calibrated strip of filter paper, fold it 5 millimeters from one end, and gently place the folded end inside the lower conjunctival sac. The source specifies placing it at the junction of the outer 1/3 and medial 2/3 of the lower eyelid margin.
And then you wait.
You leave it in place for exactly 5 minutes, or until the wet portion reaches 30 millimeters, whichever comes first. An important procedural detail from the source. If you notice that the tear fluid isn't starting to diffuse up the strip over the eyelid margin within the first 2 minutes, you should carefully reposition the strip slightly to another spot within that same general area for the remaining time. This helps avoid a false negative result if the strip placement was initially poor.
And after 5 minutes.
You remove the strip and measure the length of the wet portion starting from the fold, in millimeters. The key finding is that less than 10 millimeters of wetting after 5 minutes indicates aqueous tear deficiency. The patient isn't producing enough watery tears.
That gives a quantitative measure. Are there other diagnostic aids mentioned?
Yes, the source mentions looking for the presence of a specific molecule called epiphora in the tears, and also measuring tear osmolarity, the salt concentration. Higher osmolarity is often found in dry eye. These can help not only diagnose, but also grade the severity of the condition.
And importantly, the source reminds clinicians to rule out conditions that can mimic dry eye symptoms.
A very important clinical point. You have to consider other possibilities. Things like chronic blepharoconjunctivitis, especially if caused by Staphylococcus bacteria, rosacea keratoconjunctivitis, and allergic conjunctivitis can all cause symptoms like redness, irritation, and burning that feel very much like dry eye. So differential diagnosis is key.
Okay, once dry eye is diagnosed, how is it treated? The source, referencing table 24.1, seems to advocate for a tailored, stepped approach based on severity.
Treatment is definitely approached in a stepwise manner, escalating based on how severe the condition is. But some general principles always apply first. You need to identify and treat any underlying cause if possible, like managing Sjogren's or treating trachoma. And you need to review and withdraw any medications that might be contributing to the dryness. Environmental modifications are also crucial for everyone.
Like avoiding drafts.
Exactly. Advising patients to avoid things that increase tear evaporation, direct airflow from fans or air conditioning, dusty environments, very dry heat. Using a humidifier can help.
So starting with mild cases, what's the approach?
According to the table, mild cases start with patient education about the condition and those environmental medication changes. Then, the focus is on aqueous enhancement using artificial tear substitutes. There are many kinds of drops, gels, ointments with different viscosities and formulations. Eyelid therapy is also important, especially if there's associated blepharitis or MGD, things like warm compresses and lid hygiene, and treating any contributing ocular factors.
What gets added for moderate dry eye?
For moderate cases, the table suggests adding anti-inflammatory agents. These are typically topical medications like cyclosporine drops or short courses of topical corticosteroids to calm ocular surface inflammation. Systemic omega-3 fatty acid supplements are also recommended, and this is where punctal plugs often come in.
What do punctal plugs do?
They're tiny devices inserted into the puncta, the tear drainage openings, to partially or completely block them. This helps to conserve the patient's own natural tears on the eye surface for longer. Spectacle side shields or moisture chambers can also be added to create a more humid environment around the eyes.
And for severe dry eye, the interventions become more aggressive.
Yes. For severe cases, the table lists adding systemic medications, potentially including cholinergic agonists like pilocarpine or cevimeline to try and stimulate more tear production, or even systemic anti-inflammatory agents. Mucolytic agents, like N-acetylcysteine drops, typically 5%, can be used if there's excessive mucus or filamentary keratitis. Autologous serum tears are another option.
Autologous serum tears?
Yes. These are eye drops made from the patient's own blood serum. The serum contains growth factors and other components that can help heal the ocular surface. Specialty contact lenses, like scleral lenses, can be used to bathe the cornea in fluid and protect it. Surgical correction of any eyelid abnormalities contributing to exposure might be needed. Permanent punctal occlusion via cautery might be considered. And in the most severe refractory cases, a procedure called tarsorrhaphy might be necessary.
What's tarsorrhaphy?
That involves partially sewing the upper and lower eyelids together, usually laterally, to reduce the overall exposed surface area of the eye, thereby reducing evaporation and protecting the cornea. It's reserved for very severe situations.
That table really provides a clear structure for escalating treatment. The source also mentions a few additional specific treatments beyond that table structure.
It does. It emphasizes using artificial tear substitutes frequently and notes the benefit of using long-lasting formulations, like gels or ointments, especially at night, and preservative-free options, as preservatives themselves can be irritating with frequent use. Mild topical steroids or the 0.05% formulation of cyclosporine drops are specifically highlighted again for managing the accompanying inflammation, which is a key component of dry eye. Anything else? There's mention of a slow-release cellulose pellet that can be inserted into the lower conjunctival sac. It gradually dissolves, providing continuous lubrication. And regarding tear conservation, by blocking the drainage, it mentions using temporary dissolvable gelatin plugs first as a diagnostic trial. If the patient experiences significant relief with the temporary plugs, then permanent closure of the puncta, usually the lower ones, using cauterization can be considered a more definitive step.
Okay, that's a very thorough look at dry eye. We've covered the production side issues and dry eye. Now let's shift, as the source does, to problems with the drainage system, the lacrimal passages. The source notes these often lead to epiphora.
Right. Epiphora is the key symptom here, the overflow of tears onto the cheek. While you can get tearing from excessive reflex production, like irritation, the term epiphora usually specifically refers to tearing that happens because the tears can't drain away properly through the lacrimal passages.
So it implies a drainage failure.
Exactly. Due to some kind of obstruction or stenosis, which is narrowing, or maybe the puncta are malpositioned and not dipping into the tear lake correctly, or there's a functional disorder where the pump mechanism itself isn't working efficiently.
Okay, so epiphora is the symptom. The main disease process affecting the drainage passages is dacryocystitis, which is inflammation of the lacrimal sac.
Yes, and this condition tends to affect two main groups, according to the source. Infants and adult females over the age of 40. It can be congenital, meaning present from birth, and congenital dacryocystitis is almost always chronic in nature, or it can be acquired later in life, presenting as either an acute infection or a chronic smoldering inflammation.
Let's tackle chronic dacryocystitis first, as the source says it's more common. What are the signs and symptoms?
The absolute hallmark symptom is epiphora, that constant tearing, which often gets worse in windy conditions or with prolonged near work. On examination, you'll typically see some swelling over the side of the lacrimal sac, between the inner corner of the eye and the nose. If the sac is distended with mucus, it forms what's called a mucocoli.
A swelling full of mucus.
Exactly. You might also see some inflammation of the caruncle, that pink bit in the corner, and the neighboring conjunctiva. But the classic diagnostic sign, really crucial, is what happens when you press firmly over the lacrimal sac area.
Regurgitation.
Yes. You'll typically see mucopus, a mixture of mucus and pus, or frank pus, regurgitate back out through the puncta onto the eye. Less commonly, the pressure might force the contents down into the nose if the blockage isn't complete.
What causes this chronic inflammation and the underlying blockage?
It's most commonly attributed to a stricture, a narrowing or blockage of the nasolacrimal duct further down. This stricture itself is usually the result of chronic inflammation. And often, that initial inflammation originates from problems within the nasal cavity, things like chronic rhinitis, nasal polyps, a hypertrophied, enlarged inferior turbinate bone, or even a deviated nasal septum pressing on the lower end of the duct.
So a nose problem blocks the tear duct.
It's a very common pathway. When the duct gets blocked, tears and normal conjunctival secretions can't drain away. They stagnate and accumulate within the lacrimal sac, creating a perfect environment for bacteria to grow. The source also notes that infections of the nearby ethmoidal sinuses are frequently associated with chronic dacryocystitis.
The source really emphasizes the bacterial aspect here, calling it extraordinary. Why is that so important clinically?
This is a really critical point, especially for achieving that expert-level mastery you're aiming for. When you do a bacteriological examination of the fluid expressed from a chronically infected sac, you often find an incredible number and variety of bacteria. Staphylococci, pneumococci, streptococci, basically. concentrated versions of the normal conjunctival flora.
And the implication?
The major implication is the risk during eye surgery. This chronically infected sac acts as a reservoir of bacteria right next to the eye. If a patient with untreated chronic dacryocystitis undergoes any kind of intraocular surgery, like cataract surgery, there's a significantly increased risk of devastating post-operative infections, like a hypopyon ulcer, pus in the front chamber of the eye, or even panophthalmitis, a severe infection involving the entire eye that can lead to blindness. That's why it's absolutely essential to treat the dacryocystitis before any elective intraocular surgery.
A critical safety point. And what's the prognosis for chronic dacryocystitis if it's just left untreated?
The source is clear. It never undergoes spontaneous resolution. It just doesn't get better on its own. It tends to progressively worsen over time. The walls of the sac can become stretched and atonic, losing their muscular tone, so the contents won't even empty properly without external pressure being applied. And perhaps most importantly, there's a constant risk that this chronic infection can flare up at any time into an acute infection, forming a painful lacrimal abscess.
Okay. What about congenital dacryocystitis, the type seen in infants? What's the cause there?
This is usually due to an incomplete canalization, or opening, of the nasolacrimal duct system during fetal development. The most common site for this developmental blockage is right at the very bottom end of the duct, where it enters the nose, at the valve of Hasner. Essentially, a thin membrane fails to perforate before birth.
How is that initially managed in a newborn?
The first line of treatment is often conservative. It involves teaching the parents how to perform hydrostatic massage, also known as Krigler massage. The source describes this technique. Using a clean finger or thumb to apply firm pressure downwards and medially, starting just behind the anterior lacrimal crest over the sac area. The idea is to build up hydrostatic pressure within the sac, which hopefully will open that persistent membrane at the valve of Hasner.
And if that doesn't work, the source mentions the need for potentially more aggressive therapy if infection sets in because of the risk of spread.
Yes, that's a serious concern in infants. If the stagnant tears in the blocked sac become infected, that infection can potentially spread to the surrounding tissues, causing perceptal cellulitis, infection of the eyelid tissues in front of the orbital septum. Less commonly, it can spread behind the septum, causing orbital cellulitis, which is much more serious. And in rare, severe cases, the infection could even spread to cause meningitis.
What bacteria are common in infected congenital cases?
The common culprits mentioned in the source for children are Staphylococcus aureus, Haemophilus influenzae, beta-hemolytic streptococci, and pneumococci. So if infection develops in a newborn with congenital dacryocystitis, initial treatment involves topical antibiotic drops, continuing the sac massage several times a day, as this helps express infected material, and meticulous eye hygiene. If there's significant purulent discharge, sending a sample for culture and sensitivity testing is important to guide the antibiotic choice effectively.
If the blockage doesn't resolve with massage and drops by a certain age, what's the next step?
If there's no marked improvement in the tearing and discharge by around 9 to 12 months of age, the standard next step is therapeutic syringing and probing of the nasolacrimal duct. This is performed under general anesthesia.
Can you describe the probing method from the source? Seems important for understanding.
Yes, the source describes it quite precisely. First, the punctum, usually the upper one for probing, and canaliculus are gently dilated. Then a small blunt-tipped Bowman probe is inserted vertically into the punctum for about 1 to 2 millimeters, then rotated 90 degrees so it's horizontal, pointing towards the nose. It's advanced horizontally along the canaliculus for about 6 to 7 millimeters until the surgeon feels a hard stop. The probe hitting the medial bony wall of the lacrimal fossa.
Okay.
Then the probe is rotated again, downwards and slightly towards the midline, aligning it with the presumed path of the mesacrimal duct. It's then gently pushed downwards, through the sac and down the duct, into the nose. The source stresses that only minimal force should be used, especially in a newborn, as the duct is short and fragile. Correct alignment is key. After probing, syringing with stained saline, like fluorescein, while observing the nose or using a nasal suction catheter, can help confirm that patency has been achieved.
Is one probing usually enough?
In the majority of congenital cases, yes, a single successful probing procedure is curative. The membrane is broken and the duct stays open.
What if probing isn't successful or the blockage recurs?
If simple probing fails, secondary procedures might be considered. These include balloon dilatation of the duct, inserting a catheter with an inflatable balloon to stretch the duct, or placing a flexible silicone tube through the system to keep it stented open for a period of weeks to months. The source also notes that the use of a nasal endoscope during probing procedures has significantly improved success rates.
How so?
The endoscope allows the surgeon to directly visualize the lower end of the duct and the probe as it enters the nose, confirming correct passage. It also allows them to identify and sometimes address other contributing nasal factors, like significant hypertrophy of the inferior turbinate bone that might be obstructing the duct opening.
And just to recap, for adults with acquired NLD obstruction causing symptoms, what's the standard treatment mentioned?
For adults suffering from symptomatic epiphora or recurrent dacryocystitis due to acquired nasal lacrimal duct obstruction, the source is clear that the definitive treatment is surgical. Specifically, creating a new drainage pathway directly from the lacrimal sac into the nasal cavity by performing a dacryocystitis, or DCR.
Okay, let's quickly cover acute dacryocystitis, which the source also calls a lacrimal abscess. This sounds more dramatic.
It is. This is an acute, painful inflammation or collection of pus within the lacrimal sac or the surrounding parasistic tissues. Figure 24.3 in your source likely shows an example. The skin over the sac area becomes intensely red, swollen, and very tender. This redness and swelling can rapidly spread to involve the lower eyelid and even the upper cheek. The source notes it can sometimes be mistaken for erysipelas, which is a type of bacterial skin infection.
Then symptoms.
Severe pain is characteristic, often accompanied by a slight fever.
Where does the abscess typically drain or point if it's going to burst?
It usually points, meaning it becomes most prominent and likely to rupture slightly below and to the outer side of the lacrimal sac itself, often towards the orbital margin. This is thought to be due to pus gravitating downwards within the tissue planes. The prognosis, if it bursts spontaneously onto the skin, isn't ideal. It often results in persistent discharge and is likely to form a permanent draining tract, a fistula.
How is this acute infection managed?
Treatment needs to start immediately with general measures. Systemic antibiotics, usually oral, and intensive topical antibiotics. Applying hot fomentations or warm compresses to the area is also recommended to help localize the infection and provide comfort. Surgical incision and drainage should only be performed if the abscess is clearly pointing, meaning there's a flexural collection right under the skin that looks ready to burst.
And if incision is needed?
If it's incised, the source recommends a small incision. Gentle pressure can then be used to express the pus. Sometimes a small rubber drain, like from a glove, might be inserted briefly to allow continued drainage, and an antibiotic dressing is applied. Crucially, any pus drained must be sent for culture and sensitivity testing to ensure the chosen antibiotic is effective against the specific bacteria causing the infection.
What happens after the acute infection resolves?
Once the acute inflammation has subsided with antibiotics and potentially drainage, if the underlying chronic discharge and nasolacrimal duct obstruction persist, which they usually do, as the acute episode was likely a flare-up of a chronic problem, then a dacryocystorhinostomy, DCR, is indicated later on to fix the underlying blockage and prevent recurrences.
Okay, so epiphora is the main symptom driving patients to seek help for these drainage issues. How do doctors systematically investigate a patient presenting with epiphora to pinpoint the exact cause and location of the problem?
A thorough clinical evaluation is always the essential starting point. You need to carefully assess the lid globe apposition, how well the eyelids, particularly the lower lid and punctum, sit against the surface of the eyeball. Asking the patient to look upwards can be very revealing.
So.
It might unmask a subtler version of a lower punctum that wasn't obvious in primary gaze, or reveal mild lower lid ectropion, outward turning. Figure 24.4 in your source apparently shows a severe case of ectropion where the punctum is clearly turned away from the eye. You'll also likely observe objective signs of poor drainage. The lacus lacrimalis, that tear lake at the inner corner, will be full or overflowing, and the marginal tear strip along the lower lid edge will appear abnormally high.
And the regurgitation test?
Yes, pressing firmly over the lacrimal sac area. If this causes mucopus or pus to regurgitate back through the puncta, it's a very strong indicator of significant obstruction lower down, usually in the nasolacrimal duct.
After the clinical exam, you move on to the diagnostic syringing and probing.
These are the workhorse investigations to confirm the diagnosis and, importantly, determine the level of the blockage within the drainage system. For syringing, you typically start by dilating the lower punctum slightly. A blunt-tipped lacrimal cannula attached to a syringe filled with sterile saline is then inserted into the canaliculus. Pulling the lower lid temporally, out towards the ear, helps to straighten out the canaliculus, making insertion easier. Then you slowly inject the saline.
What are you looking for during injection?
You need to carefully observe where the saline goes and also ask the patient if they feel it trickling down the back of their throat or if they taste the salty saline. The interpretation of the results is key, and the source's table 24.2 is crucial here for mastery.
Can you summarize the interpretations from that table?
Sure. If the saline regurgitates forcefully back out through the same punctum you're injecting into, it suggests a blockage right at or very near that punctum, or within that specific canaliculus. If the saline regurgitates strongly through the opposite punctum, usually the upper one if you're syringing the lower, it implies that the canaliculus you syringed is open, the fluid got into the sac, but it couldn't get down the nasolacrimal duct. So it refluxed out the other open pathway. This pattern is highly indicative of NLD obstruction, or possibly common canalicular obstruction.
What if it goes down?
If the saline flows freely into the nose the patient feels or tastes it, and there's no significant regurgitation back through either punctum, then the entire system down to the nose is considered patent or open. Conversely, the patient not feeling any saline reach their throat is a strong indicator of NLD obstruction.
Okay, that table is definitely key for interpreting syringing results. What about probing? What information does that add?
Probing involves passing a fine, blunt-tipped metal probe, like a Bowman probe, gently through the punctum, along the canaliculus, and towards the lacrimal sac. As you advance the probe, you're feeling for resistance. The critical distinction is between a hard stop and a soft stop.
What does that mean?
A hard stop means the probe has passed freely through the canaliculus and has come up against the solid medial bony wall of the lacrimal fossa. This indicates that the pathway up to the lacrimal sac itself is likely open. Any obstruction must be beyond the common canaliculus, potentially within the sac, or more likely, the nasolacrimal duct. A soft stop, on the other hand, feels mushy or springy. It means the probe is encountering resistance from soft tissue within the canalicular system itself, indicating a blockage there.
Can probing tell you where in the canaliculus the block is?
Yes. The distance from the punctum at which the soft stop is encountered helps pinpoint the location. If the soft stop is felt relatively close to the punctum, say 5 to 8 millimeters in, the obstruction is likely within the individual canaliculus. If the soft stop is felt further in, more than 8 millimeters from the punctum, the obstruction is probably at the level of the common canaliculus, where the upper and lower ones join before entering the sac.
The source also describes the Jones dye tests. It says these are particularly useful for distinguishing functional disorders like pump failure from actual physical blockages, especially when syringing seems to show that passages are open.
Exactly. These tests assess the physiological drainage of tears under more natural conditions, rather than just the anatomical patency revealed by forcing fluid through a syringing. They are used when a patient has significant epiphora, but diagnostic syringing suggests the system is physically open.
How does Jones test 1 work?
In Jones test 1, the primary dye test, you instill a drop of fluorescein dye into the conjunctival sac of the affected eye. You then wait for 5 minutes. After 5 minutes, you check for the presence of the dye inside the patient's nose, specifically in the area under the inferior turbinate where the nasolacrimal duct opens. This is usually done by inserting a cotton-tipped applicator, perhaps soaked with a topical anesthetic, into the inferior meatus. If you retrieve the cotton bud and it's stained yellow with fluorescein, it means the dye has drained down naturally through the entire system. The test is positive, indicating the system is functionally patent.
What if test 1 is negative, no dye in the nose after 5 minutes?
If Jones test 1 is negative, you proceed immediately to Jones test 2, the secondary dye test. Without adding any more dye, you perform diagnostic syringing with clear saline through the lacrimal system. As the saline is flushed through, you again check the nose, often by having the patient blow their nose into a tissue or by using suction. If fluorescein dye now appears in the flushed saline from the nose, it means the dye did enter the lacrimal sac during the initial 5 minutes, so the upper system is okay. But it couldn't drain down the nasolacrimal duct on its own. However, the hydrostatic pressure from syringing was able to push the dye through.
What does that indicate?
A positive Jones test 2, after a negative Jones 1, suggests a partial obstruction or stenosis, usually within the nasolacrimal duct, or passively a functional insufficiency of the lacrimal pump that prevents normal drainage, but can be overcome by the force of syringing. If both Jones 1 and Jones 2 are negative, meaning no dye reached the nose either naturally or after syringing, and the initial syringing showed the system was anatomically patent, or only partially blocked with some reflux, this strongly suggests a functional blockage, like a primary lacrimal pump failure, or perhaps a very proximal partial obstruction, where the dye didn't even get into the system effectively to be tested.
It seems imaging plays an important role, too, for confirming and precisely localizing blockages.
Absolutely. Imaging can provide valuable anatomical information. Dacryocystography, or DCG, is a key imaging test. It involves injecting a radiopaque contrast dye, like lipule, into the puncta and canaliculi, and then taking X-ray images. This clearly outlines the entire lacrimal drainage pathway, the canaliculi sac and duct, and can pinpoint the exact site of an obstruction. The source notes that in adults, the commonest site for NLD block seen on DCG is right at the junction of the lacrimal sac and the nasolacrimal duct, often corresponding to the level of the inferior orbital rim on the X-ray, as shown in figure 24.6. Tumors within the system might also appear as filling defects on the DCG.
Are there variations of DCG?
Yes, the source mentions digital subtraction macrodacryocystitis with canalicular catheterization, shown in figure 24.5, as a technique that can provide even more precise anatomical detail.
And what about CT or MRI scans?
CT or MRI can also be used, sometimes in conjunction with instilling a radiopaque dye into the conjunctival sac beforehand. Figures 24.6a and b apparently show how these scans can demonstrate pooling or retention of the dye above a blockage. CT-DCG, performing a CT scan after dye injection, is noted as being particularly valuable in cases of facial trauma. It can clearly visualize the relationship of the lacrimal sac to any bone fractures and show any traumatic disruption or changes in the drainage system's anatomy.
There's also a functional imaging test mentioned, dacryocystitis. How does that work?
Dacryocystitis assesses the functional efficiency of the drainage system rather than just the anatomy. It involves instilling a tiny amount of a radioactive tracer, typically technetium-99 colloid, into the conjunctival sac, just like an eye drop. Then a special detector called an Anger gamma camera is used to visualize the passage of this tracer down through the lacrimal drainage system over time. Delayed passage or holdup of the tracer indicates poor function or obstruction.
So bringing it together, how is functional blockage diagnosed definitively when syringing seems okay?
Functional blockage is the diagnosis when a patient clearly has symptomatic epiphora. But standard diagnostic syringing, and often imaging like DCG or scintigraphy, show that the physical drainage channels are anatomically open. The cause isn't a complete physical obstruction. Potential causes include mild punctal stenosis that doesn't fully block syringing, or more commonly a failure of the lacrimal pump mechanism itself, often due to lower eyelid laxity or poor orbicularis muscle function associated with aging. This diagnosis is typically suggested by the pattern of Jones testing, negative test 1, positive test 2, or directly demonstrated by delayed drainage on dacryoscintigraphy.
The source includes an important warning note about suspecting a neoplasm, a tumor, in certain cases of epiphora. What are the red flags?
Yes, this is a critical clinical point that shouldn't be missed. While most epiphora is due to simple blockage or dysfunction, if the epiphora is accompanied by other symptoms like facial pain, persistent nasal discharge, especially if bloody, or particularly intermittent nasal bleeding, epistaxis, it should immediately raise suspicion for a possible malignant tumor originating in the nearby maxillary antrum sinus or ethmoid sinuses that might be invading or compressing the lacrimal drainage system. Further investigation with imaging like CT or MRI of the sinuses would be urgently warranted in such cases.
Okay, that covers the investigation thoroughly. Now let's drill down into the specific causes of epiphora listed in the text and their detailed treatments, which is really key for that mastery level understanding you're aiming for. First up, aversion of the lower punctum.
Right, this simply means the lower punctum, the little opening, is turned outwards, away from the surface of the eye where the tear film collects. Normally, it should sit snugly against the globe, dipping into the tear lake, lacus lacrimalis.
What causes it to turn out?
The commonest causes are related to changes in the lower eyelid position or tone. Simple lid laxity that occurs with aging is a frequent cause. Chronic inflammation of the conjunctiva or eyelid margin, chronic conjunctivitis or blepharitis, can also contribute to lid laxity and aversion. And essentially, any condition that causes frank ectropy, the outward turning of the entire eyelid margin, will inevitably cause the punctum to avert as well. Figure 24.4 in your source apparently shows a severe ectropion where the punctum is obviously averted. Clinically, you can actually see the punctum easily without having to pull the lid away, which shouldn't happen if it's properly positioned.
And the source mentions that the epiphora itself can make the ectropion worse. A vicious cycle.
It often is. The constant overflow of tears onto the skin of the lower eyelid causes chronic wetting. This can lead to inflammation, chapping, and excoriation of the lid skin. People then naturally tend to wipe their tearing eye frequently, usually with a downwards motion. This repeated downward wiping action pulls on the already lax lower lid, mechanically stretching it further outwards, which exacerbates the underlying ectropion, and thus worsens a punctal avulsion and the epiphora.
How is punctal avulsion treated?
The treatment depends on the severity. For mild avulsion, particularly in older patients where lid laxity is the main issue, a relatively simple surgical procedure called a conjunctivoplasty can be quite effective. This involves removing a small, horizontally oriented, spindle-shaped piece of the conjunctiva and underlying tarsal plate just below the affected punctum. When the edges of this excision are sutured closed, the resulting scar tissue contracts, effectively pulling the punctum back inwards towards the globe, restoring its proper position.
What if the avulsion is more marked?
If the punctal avulsion is part of a more significant established ectropion, then the simple conjunctivoplasty alone usually isn't sufficient. In these cases, a more definitive surgical procedure designed to correct the underlying ectropion itself, like a lateral tarsal strip procedure or similar lid tightening surgery, is required to restore normal lid position and punctal apposition.
Okay. Next specific cause. Punctal stenosis, which is narrowing of the punctal opening.
Yes, the opening itself becomes too small for tears to enter easily. This can be congenital, present from birth, or more commonly acquired later in life. Acquired causes include age-related fibrosis, scarring, side effects from certain topical medications, some glaucoma drops are notorious for this, chronic blepharitis causing inflammation around the punctum, or severe inflammatory conditions like Stevens-Trommelson syndrome that cause scarring.
How is punctal stenosis managed?
Non-surgical approaches aim to keep the narrowed punctum open. This might involve attempting temporary dilation in the clinic or placing small, indwelling devices. Examples mentioned include monocanalicular or bicanalicular stents, tubes passing through one or both canaliculi, perforated punctal plugs, plugs with a small central hole allowing some drainage, or simple silicone tubes passed through the punctum and canaliculus. These devices are typically left in place for a period, often around 6 to 9 weeks, and then removed, hoping the punctum stays dilated.
What about surgical correction? The source details the 3-snip operation. Can you walk us through that?
This is a classic surgical procedure specifically designed to enlarge the punctal opening by removing a small wedge from its posterior wall. The source describes the steps precisely, which is great for your mastery goal. First, the area around punctum is anesthetized, and the punctum is dilated as much as possible. Then, a special sharp-tipped instrument called a canaliculus knife is inserted vertically into the punctum and advanced downwards for about 2 millimeters. Next, the knife is rotated 90 degrees, so it's horizontal, and advanced along the canaliculus for about 6 to 7 millimeters. While the lower eyelid is kept stretched outwards, temporally, the knife is used to incise the posterior wall of the horizontal canaliculus along this path. Finally, using fine scissors, like Vanna scissors, the small triangular flap of tissue formed by the initial vertical cut and the horizontal incision of the posterior wall is carefully snipped off and removed.
Creating a larger opening.
Exactly. It effectively creates a larger keyhole-shaped opening by removing that posterior wedge, allowing tears better access into the canaliculus. Post-operatively, the source notes that occasional probing of the incised area might be needed the next day and on successive days to prevent the cut edges from healing together and closing the opening again. Placing silicone tubing through the system after the snip procedure can also help maintain patency during healing.
What about complete occlusion of the puncta, where the opening is totally sealed off?
This is less common as an isolated problem, but can occur. It can be congenital, agenesis meaning the punctum never formed, or acquired due to severe scarring, cicatricial occlusion. The source describes this as a particularly difficult problem to treat successfully.
What's the first step?
A crucial first step before attempting any repair is to verify the patency of the rest of the lacrimal drainage system beyond the occluded punctum. This is done by syringing saline through the other punctum, usually the upper one if the lower is occluded or vice versa. You need to know if the canaliculus, sac, and duct are open before trying to create a new opening at the punctum.
Assuming the rest is okay, how do you create an opening?
The goal is to surgically create an opening just at the site of the occluded punctum, trying not to slit open the entire canaliculus if possible. If there's absolutely no visible trace of the punctum, the source suggests a very careful examination with slit lamp microscope. You might be able to identify a faint dimple or a tiny pale avascular point at the exact anatomical location where the punctum should be.
And if you find that spot?
You can attempt to carefully puncture this site using the very fine point of a punctal dilator or even a sharp needle. If successful, you then try to gently dilate the opening created, hopefully enough to insert a lacrimal probe. If you can establish an opening this way, Placing temporary plugs or silicone stents through the new opening for about 3 months can help prevent it from closing down again as it heals.
What if there's absolutely no visible sign of where the punctum was, and you can't find a lumen this way?
If no punctum or dimple is visible at all, and puncture attempts fail to find a lumen, the source describes a more aggressive approach, surgically cutting down onto the presumed location of the underlying canaliculus. This might involve using a small scalpel blade, like a 15 blade, and possibly attempting retrograde probing backwards from the medial end, if accessible during another procedure like DCR. If a canalicular lumen is successfully located this way, an opening is created, and the system must be intubated with nasolacrimal silicone tubing for several months, 3 to 6 months mentioned, to keep it patent.
And if no lumen can be found even with cutting down,
If, despite these efforts, no canalicular lumen can be identified, it implies a more extensive obliteration involving the canaliculus itself. In this situation, simple punctal reconstruction isn't possible. The definitive treatment would then involve bypassing the entire blocked upper system with a conjunctival dacryocystitis, conjunctival DCR, using a Lester-Jones bypass tube, which would typically be performed at a later date.
that makes sense. This leads us naturally to occlusion of the canaliculus itself, not just the punctum.
Right. Blockage can occur anywhere along the length of the upper or lower canaliculus, or in the common canaliculus where they join. Causes can include scarring from trauma, previous surgery, or even repeated forceful syringing attempts. Chronic inflammation or infections within the canaliculus can also lead to scarring and blockage. The source specifically mentions again that prolonged use of the antiviral eye drop idoxuridine has been associated with causing canalicular obstruction.
What about foreign bodies?
Foreign bodies can also occlude the canaliculus. The commonest one mentioned is simply a retained eyelash that has somehow migrated into the punctum and lodged within the canaliculus. Often the end of the lash might still be projecting slightly from the punctum, making it relatively easy to grasp and remove. Less frequently, the blockage can be caused by canalicular concretions.
Concretions, what are they?
These are firm, often yellowish granular masses that form within the canaliculus. They are typically composed of colonies of bacteria, most commonly Actinomyces species. Actinomyces are gram-positive anaerobic bacteria that tend to form dense, tangled networks, sometimes referred to as sulfur granules because of their appearance.
How are concretions removed?
Treatment involves dilating the punctum and, if necessary, slightly slitting the canaliculus open, a canaliculotomy, to gain access. The concretion mass is then carefully removed using a small curette or forceps. After removal, the source recommends irrigating the canalicular system with an antibiotic solution, specifically mentioning penicillin, to treat any residual actinomyces infection.
The source also briefly lists congenital anomalies of the puncta and canaliculi as potential causes of drainage issues from birth.
Yes, these are structural variations present from birth that can affect tear drainage. Examples mentioned include completely absent agenesis or severely constricted stenotic puncta, the presence of 2 puncta in a single eyelid. These usually drain into the same single canaliculus. Or occasionally, instead of a formed canaliculus, there might just be an open groove along the eyelid margin.
So, canalicular obstruction, whether congenital or acquired, is importantly classified by its location relative to the punctum. Why is that distinction important?
Yes, the location is key for treatment planning. Obstructions are generally divided into proximal blockages, defined as being less than 8 millimeters from the puncta, and distal blockages, which are more than 8 millimeters from the puncta, closer to the lacrimal sac. This distinction helps guide the surgical approach.
How are proximal canalicular blocks less than 8 millimeters from the puncta typically treated? The source mentions a specific procedure.
The standard treatment approach described in the source for proximal canalicular obstruction, where there isn't enough healthy canaliculus remaining laterally to reconstruct, is conjunctival dacryocystitis, or conjunctival DCR. This procedure involves creating a completely new drainage channel that bypasses the blocked canaliculus altogether, connecting the conjunctival sac directly to the nasal cavity, usually using a permanent indwelling bypass tube. The most common type of tube used for this is the Lester-Jones Pyrex glass tube.
Are there issues with these tubes?
Yes, the source notes potential complications, primarily displacement or extrusion of the tube. Various modifications to the tube design have been developed over the years, like adding suture holes, roughening the surface, or using porous coatings to try and improve its stability and reduce these problems. The source also mentions that retrograde intubation DCR, performing a DCR and then trying to intubate the blocked canaliculus backwards from the sac, has been attempted for these proximal blocks, but states it has had limited success.
Okay. And what about obstructions that are further down distal obstructions, more than 8 millimeters from the punta, or blockages involving the common canaliculus where the upper and lower join?
When the blockage is located more medially, closer to the sac, or involves the common canaliculus, a less invasive approach might be attempted first, aiming to reopen the natural pathway if possible. The source mentions attempting to open the blockage using a specialized instrument called a canalicular trephine. If successful, this is typically followed by standard silicone intubation of the canalicular system using either monocanalicular single tube or bicanalicular loop tube stents to keep the open channel pattern while it heals.
Are there specific stents mentioned?
Yes. The source mentions a self-retaining bicanalicular intubation set, which features silicone tubing with flexible winglet-like heads designed to help hold the tubing securely in place within the canaliculi without needing sutures. However, if there's also an associated blockage further down in the nasolacrimal duct, or if the attempt to open the distal canalicular block with a trephine fails, then a more extensive surgical procedure is required. This involves performing a standard DCR combined with surgically opening and intubating the obstructed distal canalicular system. This combined procedure is specifically referred to as canalicular dacryocystitis.
Right. And that brings us finally to the most common cause of epiphora in adults overall, nasolacrimal duct, NLD, obstruction.
Yes, this is the primary reason for acquired lacrimal drainage problems in the adult population. The blockage occurs within the bony duct that runs from the bottom of the lacrimal sac down into the nose. As highlighted again in Table 24.2, the most common site for this blockage is right at the junction where the lacrimal sac transitions into the nasolacrimal duct.
What causes the duct to block?
The most frequent underlying cause is thought to be chronic inflammation within the duct lining, which eventually leads to fibrosis, scarring, and the formation of strictures that narrow or completely block the passage. The causes are broadly divided into idiopathic, also called primary acquired NLD obstruction or PANDO, which is the most common type, meaning no specific identifiable cause is found, and secondary NLD obstruction, where the blockage is due to known factors.
What kind of secondary factors?
Things like facial trauma involving fractures near the duct, tumors arising in the sinuses or nasal cavity that compress or invade the duct, iatrogenic injury, accidental damage during previous sinus or facial surgery, or fibrosis resulting from radiation therapy to the head and neck area.
What are the direct consequences of the NLD being blocked?
The blockage prevents the normal drainage of tears and conjunctival secretions from the lacrimal sac down into the nose. This leads to stagnation and retention of these fluids within the sac. As we discussed earlier, this frequently results in recurrent episodes of chronic dacryocystitis, infection of the sac. The sac can become progressively distended with mucoid secretions, forming a palpable swelling known as a mucocele, which is clearly shown in figure 24.7 of your source.
And pressure causes regurgitation?
Typically, yes. Applying pressure over the swollen mucocele will cause the retained mucoid or mucopurulent material to regurgitate back up through the puncta. On diagnostic syringing, as we establish, you'll get reflux of first mucoid, then clear fluid, usually through the opposite punctum, and the patient will report not feeling any saline entering their throat. Clinically, you might see or feel a distinct rounded mass just below the medial canthal tendon.
The source mentions something called an encysted mucocoate.
Yes. Occasionally, a patient might have a palpable mucocele, but when you press on it, no regurgitation occurs through the puncta. This is referred to as an encysted mucocele. It usually implies that in addition to the NLD blockage, there's also a secondary stenosis or blockage higher up, either within the wall of the sac itself or a stricture at the common canaliculus, which prevents the contents from being expressed backwards. It's particularly important if you find a palpable mass in the sac area, especially if it feels firm or is painful, to rule out other possibilities besides a simple mucocele.
Like what?
Things like a space-occupying lesion within the sac, such as a fungal ball, dacryolymph, or even a neoplastic growth tumor. The source recommends considering imaging, such as CT-DCG, if a mass is palpable, particularly if it doesn't regurgitate, to exclude these more serious underlying causes.
So putting it all together, the standard treatment for NLD block causing symptoms varies depending on the patient's age, correct?
Yep.
Yes, the approach differs significantly between infants and adults. In infants with congenital NLD block, as we covered, the initial approach is conservative. Antibiotics if infected, and regular sac massage. If the epiphora persists beyond about 9 months of age, probing under general anesthesia is the next step and can be repeated if necessary. However, if significant chronic epiphora continues beyond the age of 3 years, DCR surgery becomes necessary, as the facial bones are considered adequately developed by then, and further probing is much less likely to be successful.
And for adults with acquired NLD obstruction.
For adults with symptomatic acquired NLD obstruction, the definitive treatment recommended in the source is surgical, dacryocystitis, DCR, to create that bypass channel into the nose.
We've mentioned DCR and other surgical procedures several times now. For that deep, expert-level understanding you're aiming for, let's walk through the steps of these key operations as they're detailed in the source material. Starting with the gold standard, dacryocystitis, DCR.
Okay. DCR aims to create a direct opening between the lacrimal sac and the nasal cavity, bypassing the blocked nasolacrimal duct. It can be performed under either general or local anesthesia. The traditional external approach, involving a skin incision, is still considered the gold standard by many surgeons due to its consistently high success rate, often quoted as over 90%.
How does the external DCR begin?
The procedure typically starts by preparing the nasal cavity on the same side as the blockage. This involves spraying and packing the nose with solutions containing local anesthetic and a vasoconstrictor, like adrenaline or oxymetazoline, to reduce bleeding and improve visualization. The lacrimal canaliculus is usually dilated, and the sac might be irrigated to clear out any retained mucus or pus.
And then the skin incision.
A skin incision is made on the side of the nose, near the inner corner of the eye. The source gives a couple of options for incision placement. One is a straight vertical incision starting about 2 millimeters above the medial palpebral ligament and 3 millimeters nasal to the inner canthus, extending downwards for about 8 millimeters. Another option mentioned is a straight incision starting about 11 millimeters medial to the medial canthus. An important technical point is that the skin and underlying tissue on the temporal side, towards the eye, are undermined slightly to create a flap, but the nasal side is generally not undermined to preserve blood supply.
Then you work your way down to the bone.
Yes. The orbicularis muscle fibers encountered under the skin are carefully split or retracted. A surgical retractor is inserted to expose the underlying periosteum covering the bone over the lacrimal crest and fossa. The periosteum is incised vertically and carefully lifted off the bone using an elevator, fully exposing the bone of the lacrimal fossa medial to the anterior lacrimal crest.
And then you make the bony opening.
Right. The bony anterior lacrimal crest is removed using a bone punch or wrong-her. This initial opening into the lacrimal fossa is then enlarged, usually downwards and posteriorly, creating a generous bony window, an osteotomy, between the lacrimal sac fossa and the adjacent nasal cavity.
Now you connect the sac to the nose.
Exactly. The medial wall of the lacrimal sac, now exposed through the bony window, is incised vertically. This incision goes through the periosteal covering and the sac wall itself. The surgeon identifies the internal opening of the common canaliculus into the sac to ensure it will be incorporated into the new opening. Then flaps of nasal mucosa are carefully created from the lateral nasal wall, visible through the bony window. These nasal mucosal flaps are then meticulously sutured to corresponding flaps created from the anterior and posterior walls of the open lacrimal sac.
Creating the anastomosis.
Precisely. This suturing creates the new direct passageway, the anastomosis, between the lacrimal sac and the nasal cavity, completely bypassing the obstructed nasolacrimal duct below.
Is silicone tubing often placed during DCR?
Yes, it frequently is, especially in cases where there's associated stenosis, narrowing of the common canaliculus, or if it's a revision DCR procedure being done because a previous one failed. In these situations, a loop of flexible silicone tubing is often passed through both the upper and lower puncta, threaded through the canaliculi, across the newly created anastomosis, and down into the nasal cavity. The ends are usually tied together or secured in the nose. This tubing acts as a stet to keep the new passage open during the healing process, and is typically removed after several months, maybe 4 to 6 months later.
The source also mentions less invasive DCR techniques.
It does. Endoscopic transnasal dacryocystohinostomy, often called internal DCR or endo-DCR, is performed entirely through the nostril using an endoscope and specialized instruments. This avoids any external facial scarring, which is a significant advantage for many patients. It's often the preferred approach if there's also an associated nasal disorder, like polyps or a deviated septum, that needs to be addressed concurrently. Another technique mentioned is transcanalicular laser DCR.
Laser DCR.
Yes. This involves passing a fiber optic probe carrying laser energy through the canaliculus to reach the lacrimal sac. Under nasal endoscopic visualization, the laser is used to ablate, vaporize the tissue and bone between the sac and the nasal cavity, creating the opening. The source notes, however, that the success rates reported for laser DCR have been somewhat variable compared to external or standard endoscopic DCR, and ultrasonic bone aspirator is also mentioned as another tool that can be used to create the bony opening in either external or internal approaches.
Okay, that covers DCR well. Next surgical procedure detailed is conjunctivodacryocystohinostomy with a Lester-Jones tube. The source specifies this is used for persistent epiphora when less than 8 millimeters of the lateral canaliculus remains open, basically for severe proximal canalicular blocks.
That's right. This is a bypass procedure for when the natural canalicular pathway is essentially unsalvageable close to the punctum. The operation starts very much like a standard DCR, including making the skin incision, creating the bony osteotomy between the lacrimal fossa and the nose, and suturing the posterior mucosal flaps, connecting the back wall of the sac remnant, if present, to the nasal mucosa.
What's different then?
After these initial DCR steps, the caruncle, that small pink fleshy nodule right at the inner corner of the eyelids, is surgically excised. Then a completely new track or passage needs to be created directly from the conjunctival cul-de-sac, the tear lake area, into the nasal cavity, bypassing everything else. The source describes creating this track using a large bore needle or a specialized trocar.
Where is this track made?
The needle or trocar is inserted through the conjunctiva at the site of the excised caruncle, aiming in a slightly downward and backward direction. The goal is to pass just behind the anterior mucosal flap created during the DCR, staying anterior to the ethmoid sinuses and the middle turbinate bone, and entering directly into the nasal cavity through the bony osteotomy.
Creating a completely new artificial drain pipe path.
Exactly. It's a direct bypass from the inner corner of the eye straight into the nose. This newly created needle track is then enlarged using instruments like a grape knife or progressively larger probes until it's wide enough to accommodate the bypass tube. The required length of the Lester-Jones tube is then carefully measured, often by inserting a probe through the track down to the nasal septum and then subtracting about 2 millimeters from that length.
And then the Lester-Jones glass tube is inserted into this track.
Yes. A Lester-Jones Pyrex glass tube of the appropriate measured length is carefully inserted into this surgically created bypass track. These tubes typically have a small collar or cuff at the conjunctival end to help hold it in place within the conjunctival fornix, and the medial nasal end is usually beveled. Figure 24.8 in your source likely shows the tube positioned correctly. If possible, the tube might be secured with some internal absorbable sutures to reduce early displacement. The DCR procedure is then completed around the tube, closing the anterior flaps and the skin incision.
What are the common issues with these Jones tubes?
The main problem is potential blockage, usually from inspissated dried mucus accumulating inside the glass tube, which requires periodic flushing or sometimes removal for cleaning. Displacement or complete extrusion falling out of the tube can also occur, sometimes requiring repositioning or replacement, which can be difficult and usually needs local anesthesia. The source also makes a specific point that Lester-Jones tubes are generally not recommended for use in children due to the potential for displacement and the need for long-term maintenance.
Right. Finally, the source details canalicular dacryocystorhinostomy. This sounds like a combination procedure. When is it used?
It is a combination. The source indicates this procedure is used for epiphora caused by a blockage in the canaliculus that is located more than 8 millimeters medially from the punctum, meaning the obstruction is in the distal part of the canaliculus or involves the common canaliculus, but there's still some healthy canaliculus remaining laterally.
So what does the operation involve?
In this procedure, the surgeon attempts to reconstruct the natural pathway. It involves carefully dissecting out the common canaliculus and often parts of the distal upper and lower canaliculi, depending on the extent and location of the blockage. Any strangulating fibrosis or scar tissue, often found near the medial palpebral ligament that might be causing the obstruction, is meticulously removed or excised.
And then you reconnect things.
Yes. The goal is to then anastomose, or surgically reconnect, the opened end of the remaining healthy common canaliculus, or the joined ends of the upper and lower canaliculi, directly into the side of the lacrimal sac. This restores continuity from the patent lateral canalicular system into the sac. This canalicular anastomosis is then followed by completing a standard dacryocystohinostomy, creating the opening between the sac and the nose to ensure drainage from the sac onwards.
And intubation is mandatory for this specific procedure?
Yes. The source states that for canalicular dacryocystohinostomy, intubation of the reconstructed canalicular system using lacrimal stents or silicone tubing threaded through the anastomosis and down into the nasal cavity is considered absolutely mandatory. This tubing acts as a crucial scaffold, keeping the delicate canalicular anastomosis open while it heals and preventing it from scarring shut again. The tubing is typically maintained in position for a relatively long period, approximately 6 months before being removed.
Wow, that is an incredibly detailed journey through the anatomy, the physiology, all the things that can go wrong, how they're diagnosed, and the intricate surgical repairs for this lacrimal system.
It truly is a complex and fascinating area. And as the source summary rightly reinforces, maintaining a healthy, stable precorneal tear film is absolutely essential not just for comfort, but for clear vision and the overall health of the ocular surface. Dry eye disease is incredibly prevalent, and accurate diagnosis really hinges on carefully assessing the tear film itself, using tests like TVUT and Schirmer staining, and thoroughly examining the meibomian glands and eyelids to pinpoint the specific underlying mechanism, whether it's aqueous deficiency, evaporative issues, or often a combination.
And for the drainage system problems.
Drainage system abnormalities, on the other hand, typically manifest primarily as that troublesome symptom of epiphora. Comprehensive investigation using clinical assessment, diagnostic syringing, and probing, the Jones dye test, and appropriate imaging is critical to precisely locate the level of the obstruction within the lacrimal passages.
And that specific diagnosis is what dictates the treatment approach, especially the choice of surgical procedure.
Exactly. The source makes it very clear that the choice of which lacrimal procedure to perform is highly dependent on several key factors: the patient's age, infant versus adult, the specific underlying cause of the problem, for example, simple NLD block versus canalicular scarring, and crucially, the exact anatomical site of the obstruction within the lacrimal drainage system. Mastery in this area means understanding not just the various problems, but the specific tailored solutions based precisely on where the problem lies.
We definitely set out to go deep today, aiming to cover every single detail in the text provided to help you reach that level of expert mastery. I feel like we've done exactly that, exploring everything from those microscopic accessory glands right through to the intricate steps of bypass surgery like the Jones tube placement.
Building that foundation layer by layer, understanding how each component works, how its failure impacts the whole system, and then how we can intervene that really is the key to achieving true mastery of this topic.
Absolutely. And as we wrap up this very deep dive, just take a moment to consider this. How such a seemingly small and often completely ignored system, the production and drainage of your tears, is actually so intricately wired into complex neural pathways, depends entirely on the precise mechanical action of facial muscles like the orbicularis oculi with every blink, and can be significantly affected by widespread systemic diseases or even common medications. A tiny blockage, a subtle change in tear composition, or a slight misalignment can have a surprisingly profound impact on something as fundamental as how comfortably and clearly you see the world every single day.
A remarkable system. Definitely something for you to mull over until our next deep dive.